Welcome back. We will continue our lecture on abnormal labor. And in the last part of the lecture, we discussed about how do we plot the cervicogram part of the partogram. Just a reminder that we start plotting partogram when the woman is in active phase of the first stage of labor. Now, how do we define active phase? That varies from place to place, but for our course, we are taking it as 4 centimeters. The WHO has recently changed it to 5 centimeter, and in the USA, they take it as 6 centimeter. Anyway, so we mentioned about this alert line and action line, which are 4 hours apart, and the labor is considered satisfactorily progressing when the pattern of labor progress, when we plot it, it is to the left of the alert line, like it should be higher than this. Okay, if it is delayed, if it crosses the alert line, then we just reevaluate, and if it crosses the action line, then we have to deliver the patient, which is usually by c-section, actually. Now, if you remember, we said we gave examples of these two different patterns which a woman might have, right? So a woman in labor might have this kind of pattern of progressive labor, another one can have like this. So in general, there are three patterns of labor, abnormal labor. But first, let's see when we plot it on a partogram, just to let you know. So here they have taken it latent as 3 centimeter, okay? Because previously, like initially when the partograms were started, they took latent phase as 3 centimeter. Now, just forget about that 3-4 centimeters. So look at the normal labor. So how does the normal labor progress? So there is a latent phase which is slow, which takes time. Actually in real life it may be even slower than this. And remember that this is just for understanding. We do not plot partogram when patients are in latent phase. And the active phase, once patient reaches the active phase, then things accelerate. Okay. So now there are three abnormal types of labor, and one of them, actually it's not even plotted on the partogram, but this is, we have plotted it here just for understanding. Okay. First means prolonged latent phase. Like the as the name suggests, the latent phase is very long compared to what we expect. Remember that we don't plot partogram or in the latent phase. So the latent phase is very long. But when the patient reaches the active phase, then it goes normally. Okay. The second pattern is primary dysfunctional labor. Primary dysfunctional labor means the labor is slow from the beginning till the end, even in the latent phase. See, compared to a normal labor, it's just taking very much time. Okay. And then the last one is secondary arrest. Secondary arrest means initially things were fine, especially till 6-7 centimeter. She's progressing well, and after 6-7 centimeters, the she does not progress. That's it. Okay, so she stops to progress. Okay. Before I move forward and discuss these three patterns, first we you need to know that now partogram is being replaced by this WHO care labor care guide. This is again a same document, but it is replacing partogram. But still, in most hospitals where partogram is being used, it's partogram and not labor care guide. Okay. What are the main differences? They have removed the alert and action line, and they have also added plotting on the during the second stage of labor. These are the main differences. Okay, but that's it. Okay. Now, latent phase of first stage of labor. An abnormally long latent phase is defined as 20 hours for the nulliparous and 14 hours for the multiparous women. Okay, so but in different places you may find it a little bit different, but in general, this is considered for nulliparous, it's 20 hours, imagine, like almost one day, and multiparous, it's 14 hours, and some women it's longer than that. Begins as short, mild, irregular. Okay, and a long latent phase means like more than 20 hours and more than 14 hours. Okay, begins as short, mild, irregular uterine contractions that soften a face and begin to dilate the cervix, of course, as always in labor. Okay. what is the problem with prolonged latent phase, especially if it's a primary gravida? They, because it's their first time, they think that they are in true labor. They come to the hospital, the healthcare provider examines them and they say it's too early. If the CTG is normal and it's not usually a private setup, they can be sent home just to relax. But the problem is they feel anxious, right? The family becomes anxious even if you admit them. Ideally, we should not admit them, but in private setups, the practices may be different. So there is a lot of anxiety. They just keep asking the healthcare professional, when will she deliver? What is the situation going on? And it's a lot of pain and a lot of anxiety. Okay. However, there are certain risks associated with prolonged latent phase. Okay. If it's abnormally prolonged, for the mother, there are higher chances of having cesarean sections. Mothers are exhausted because it is not, they are not even in actually true labor, right? And then the healthcare professionals, they are pressurized, they feel pressurized to do something. And then what they can do, they can either augment if it allows, if the cervix is a little bit dilated, or they can induce, right, even. And then what will happen, both of these can lead to unnecessary c-sections. There may be fetal distress, unnecessary c-sections. Okay. Longer hospital stays for the neonate, yeah. If it is abnormally long, yes, baby may get distressed ultimately. So there are higher rates of perinatal morbidity, more likely to require neonatal intensive care unit admission, may have meconium, and are likely to have depressed EPCAR scores. What is the best treatment? Of course, you make sure that baby is doing well, right? Okay. So, okay, just forget about this one. Just delete this one. Okay, this is not about the latent. Okay. So it is more common in primiparous women. Artificial rupture of membrane or oxytocin infusion, which is augmentation, right, will increase the likelihood of poor progress later in the labor and the need of cesarean birth. It is best managed away from the labor suite with simple analgesics, mobilization, and reassurance. The partogram should not be commenced until the latent phase of labor is completed. Okay. The next one is primary dysfunctional labor, which means from the beginning it's very slow. Remember, we said in 4 hours the minimum is 2 centimeter. Okay. The term is used to describe poor progress in the active phase of the first stage of labor when there is less than 2 centimeter cervical dilatation per 4 hours, and is also more common in primiparous women. So it just, things are like slow, slow, slow. They haven't crossed the action line, but they're slow. It is more commonly caused by inefficient uterine contractions, but it can also result from CPD, malposition, and malpresentation. So, whatever is the pattern of abnormal labor, we always have to rule out the three P's. That there is, it's not a malposition, it's not a malpresentation, the power is, uterine contractions are good, and there is no CPD. Okay, we always have to reassess. Okay. Secondary arrest, we said initially things were doing well till they were 7 centimeter, but then after 6, 7 centimeter, they usually start to slow down. Okay. So occurs when progress in the active first stage is initially good but then slow or stops altogether, typically after 7 centimeters dilated. Now this one is mainly in multiparous women usually. Okay. Yes, it can also happen in priming, but like macrosomic babies. Okay, CPD usually. Inefficient uterine contraction, always rule out the three P's. Okay, CPD feature more commonly than in primary arrest. Okay, so in multiparous, if it is secondary arrest, it may be a macrosomic baby. It's a CPD most likely. Okay, it may be relative, right? If it's a macrosomic baby. So, but we always rule out fetal malposition and fetal malpresentation. Now, so dystocia means slow progress, right? Poor progress in the first stage. If it is slow, then what we can do, one of the options is we can do ARM. It is also called amniotomy. So, but after amniotomy, we can start oxytocin. Okay. Oxytocin is typically infused to titrate dose to effect, as prediction of a woman response to a particular dose is not possible. What does that mean is we always start with low doses and then monitor uterine contractions, and then if needed, the dose of oxytocin is increased. This is called amnio hook. Amnio hook is used, it's a disposable thing. So perform artificial rupture of membrane, just see if she progresses well, and if needed you can start oxytocin. Okay, if her uterine contractions are inefficient. Now Then poor progress in the second stage of labor. Do not confuse poor progress in the second stage of labor with secondary arrest. Secondary arrest happens in the first stage of labor, right? After 7 centimeters. And then arrest in the second stage of labor means the patient is fully dilated, second stage, but still head is not coming down. She's not being delivered. So always we have to rule out. Delay in the second stage can occur because of a narrow mid-pelvis, which prevents internal rotation of the fetal head. One of the things is, okay, maybe CPD even. Or we have to rule out deep transverse arrest. Remember when the baby's head was engaged, the widest part of the baby entered the widest part of the pelvis, which was the transverse, right? But if there is no internal rotation during the mechanism of labor, the baby will come down as deep transverse arrest, as transverse. And now, because baby's head, when it is delivered, it is by extension, right? First, it should have internally rotated so that we can see the nape of the baby's head. So, deep transverse arrest, we cannot deliver it. Either we have to rotate it, say for example Killian's forceps, or we have to perform a C-section. Okay. Delay can also occur because of a persistent occipito-posterior position of the fetal head, which is related to passenger. In this situation, the head will either have to undergo a long rotation. Do you remember, like we discussed how it the possibility of rotation, but there is also possibility that direct occipito-posterior can also deliver as face to pubes. Okay, we discussed this in another lecture. So so arrest in the second stage of labor, this is the continuation, okay? So do not confuse it with secondary arrest. Occurs when delivery is not imminent after the usual interval of pushing in the second stage of labor, maybe due to inefficient uterine activity. Sometimes happens that the woman is fully dilated, but still her uterine contractions are gone. So even in second stage of labor, sometimes we need to start oxytocin. Again, rule out malposition, malpresentation, CPD may be due to maternal exhaustion. So whatever the reason, be it in first stage or second stage, whenever there is delay, always rule out, always reevaluate for the 3 Ps. That's it. Okay. And that's it. So I took it from the 10 teachers book. If you have any questions,